Hi, I'm Jane Goodall. This is Charles. He's consented to a lumbar spine examination. He's no underlying pathology and is fit and well. So after taking a complete history, we'd start by assessing Charles's kinetic chain and core stability. So Charles, if you can walk steadily over to the screen and then back again, and we're looking at smoothness and symmetry of his gait, normal heel, strike, toe off gait, any signs of antalgia, foot drop, which could indicate common peroneal nerve or sciatic nerve palsy, any waddling gait or side to side sway, which can indicate weak hip abductors. So now if you can walk on your tiptoes for me and then back on your heels for me, Charles, and we're now evaluating about 90% of his neuromotor function, which he seems to be coping fairly well with, so it shows good integrity of his nerves and muscles. So we're going then to inspect Charles from the front and sides and back. And anteriorly we're looking at general alignment, so we're looking for signs of any pelvic tilting, put your feet together, femoral anteversion, any knee varus and valgus, and then put them apart. And then we'll look for signs of pes cavus or planus, any tibial torsion. That's lovely. Any signs of scars indicating previous surgery or trauma, erythema, swelling. Laterally, we're looking at the head and neck posture and the curves of the spine, which normally should be a cervical lordosis, thoracic kyphosis, and a lumbar lordosis. Then looking at Charles posteriorly, we're looking again for symmetry, lateral muscle masses, comparing bilaterally, signs of atrophy, hypertrophy, fasciculation. We'd also be looking at the spine. Is it straight? Is there scoliosis there? Any apparent leg length differences? That's great, Charles. And then if you just turn forward, and then we're actively going to assess Charles with range of movement in his lumbar spine. So if you can just bend forward to touch your toes, Charles, as far as you can go. Any discomfort there? Mm-hmm. And then come back up. If there was any pain there, it may indicate that there's a lumbar disc related problem. And then bend back towards me. Any discomfort there?
No.
Great. And that could, if there was, it could indicate, we'd be thinking something like a facet joint or a spinal stenosis or a spondylolysis, spondylolithiasis. And then slide your right arm down your right leg, Charles, as far as you can comfortably go, and then left arm down left leg. And again, we're looking for symmetry and flexibility, and then twist your upper body round to the right and then round to the left. And the same again into rotation. It's great. And then if you take a seat here with your back towards me. Thank you, Charles. So now stabilise the pelvis. We can palpate the spinous processes. That's great. Any tenderness there?
No.
And we can palpate over into the sacroiliac joint. Any problem there? Okay. Also the erectus spinae. Any problems?
No.
And further out into the quadratus lumborum. No problems there. Okay. So now if you can bend forward for me, Charles. And in forward flexion, we're looking to see if there's any signs of scoliosis or an exacerbated scoliosis that we found in standing. And then we can actually spring the spinous processes here and check for any signs of hypermobility or rigidity, and also we're checking for any irregularities. So there may be a lumbar shelf there that could indicate, around the L4, L5 could indicate spondylolithiasis. Checking for spina bifida, you'll check that there might be growth there, hair around that region as well, and also checking for any signs of sacralization or lumbarization. So Charles, you can bend backwards into my hand. That's great. So we're seeing how much lumbar lordosis Charles can create there. That's great. And then side bend to your right hand side. That's lovely. And then round to your left hand side. So we're looking at symmetry and flexibility and side bending, and then twist round to your right hand side, and then round to the left. And again, same thing for rotation as well. That's great. Charles, if you could just stand back up here for me a second. I'll also do a stalk test as well. So what I'm going to do is just ask you to stand on one leg for me, and then you're going to bend backwards. And any discomfort there?
No.
If there was any pain or discomfort on the ipsilateral leg that's with the planted foot, that can indicate either a spondylolysis or a potential sacroiliac joint problem. We'd also repeat that on the other leg. So if you now lie on your side, please. That's great. Great. So we continue palpating. We can palpate into the gluteus muscles there. That could be, again, tender, secondary to trauma, or there could be a problem with a lumbar disc and referred pain there. There could also be decreased tone, which could indicate a nerve root problem. So to find the ischial tuberosity and the greater trochanter, we can locate midpoint and palpate there where the sciatic nerve should be quite palpable. If it's tender or irritated, it does pass through the glutes and also below the piriformis where it can be compressed sometimes. Any tenderness there?
No.
That's great. Okay. I can also, from this position, just go on to doing a bit of passive testing as well. So we'd move along the lumbar spine and we'll be testing between the spinous processes, so we'll be flexing up into flexion, and we can put some axial compression into extension. We can palpate the transverse processes as well, and we can passively test up as well into side bending, and if we wanted to add in some rotation as well. Okay, that's great. Lovely. I'm going to do a few little tests for instability. So if you lie onto your tummy, Charles, knee. That's great. So one of the ways we can do this is to apply a bit of postero anterior pressure through. Any tenderness there?
No.
If we elicited any pain there, that would be a positive sign. We could go to the passive lumbar extension test. So what I'm going to do, Charles, I'm just going to lift your legs and then pull gently. So we'll be lifting about 30 centimetres and then gently pulling. If there was any severe pain or heaviness experienced, that would be a positive test. And then I'm going to ask you, Charles, if you can just stand over the bed here, in front of the bed, and then you're going to just lie forward onto that for me. That's great. So with his feet on the floor, this is a prone instability test. So I'm going to again apply a bit of pressure throughout his lumbar spine. If there's any pain elicited there, what I'm getting to do is just raise both your legs up off the floor, Charles. And if the pain, once I'm pressing again, if the pain disappears, relax there. That's a positive test, and that would indicate there's some muscle guarding going on there and protecting underlying instability such as a spondylolisthesis. Okay, Charles, that's great. And then if you want to just lie onto your back for me. So another test we can do is the Faber test, which is an acronym for flexion, abduction, external rotation of the hip during the hip position during the test. So I'm just going to stabilise your pelvis here. Is there any discomfort there?
No.
So if there was restricted range of movement and pain in the hip, that would be indicative of a intra-articular problem, such as a labral cyst or osteoarthritis. If I apply a little bit of pressure, any pain that's localised into the sacroiliac joint would indicate a problem there, a dysfunction in the sacroiliac joint there. Okay, that's lovely. I would then go on to doing a neurovascular screen. So I'm just going to test sensation, Charles. So just tell me if it's the same both sides.
Yeah.
L4,
Yeah.
L5,
Yeah.
S1. And then I want you to pull up your feet towards you with as much strength as you can. That's great. So that's L4, my toes, and then L5. Push up your big toes, as much strength as you can, and then push down your feet as much strength as. So that's S1. Okay, that's great. Wiggle your toes. Fantastic. And then I would check for capillary refill. That's great. And dorsal pedal pulsus. And the posterior tibial pulses. That's great. I'd then do a provocation test for the to provoke symptoms of a sciatic nerve impingement or a disc problem. So what I want you to do is elevate this leg as far as you can go, Charles. Any discomfort there?
No.
If there was pain, just drop that down a little. I would then try and exacerbate symptoms by dorsiflexing the foot, and if there was shooting pain going down past the knee into the foot, this would be a positive test for a sciatic nerve impingement or a disc herniation. To alleviate that, I would bend the knee and plantar flex. That should alleviate any of the tension sign we have there. That's great. Okay, that's lovely. We could also do tests to compare on the other side, and if that actually provoked pain on the involved side, it could indicate a larger herniation as well. Okay, so to complete my examination, I would want to do a full neurovascular assessment. I'd want to examine the spine above and the hips below, and if required, I would request further imaging as well, such as an X-ray or MRI. Okay, thank you, Charles.